I'm happy to be here today. My name is Michael Warren. I work with the State Department of Health. I'm really excited to have Dr. Kim Wyche-Etheridge, whose name you have heard lauded many times already this morning. She is the Director of Services for Infants, Youth, and Families at the Metro Nashville Health Department. And as you heard Dr. Liu say, is actually one of the national co-leaders for the COIN, the Collaborative Innovation and Improvement Network, around the area of safe sleep. So you have a national expert in the room with you to learn, no pressure, to learn from today. So unfortunately, we don't have disclosures. Sometimes we wish we had disclosures, but we don't have any financial disclosures. And we're not going to be talking about any drugs or products, so no off-label issues. But we're going to start with a quiz, because you've been sitting for a while. We want to make sure your brains are moving. Which of these is the safest infant sleep environment? A, B, C, or D? C, good. We kind of have an audience that should know this, so I'm glad you got this right. But if I ask you the question, which of these looks the most comfortable or cozy or warm and inviting, would C have necessarily been your answer? No. And that's what many folks in the public would say if they look through this. In fact, if you look through magazines or you look through catalogs or you walk down the baby aisle at a department store, this barren crib that is in C that we know as the optimal sleep environment is not what you see marketed or pictured in those advertisements. So what we hope to do over the next few minutes is talk about the epidemiology of safe sleep or sleep-related deaths in Tennessee. We're going to outline the latest recommendations for infant safe sleep. And then we're going to spend a few minutes reviewing the literature on safe sleep knowledge, practice, and interventions. And hopefully by the end, identify some opportunities for promoting safe sleep in your communities. So just to set the stage for what we think about when we think about sleep-related deaths in Tennessee. So a couple of bars here. We tried to make this Tennessee orange, but it doesn't project very well. Tennessee are the orange bars on the left. And you can see as we've gone from 2005 to 2010, this is what you've already heard this morning, our infant mortality rate is improving. Now the blue bars are the national average, and so we're still higher than the national average, but we're moving in the right direction. In 2010, 7.9 deaths for every 1,000 live births. If you look at that a different way, Dr. Gunn talked about it's important to think about the numbers behind those rates. So the numbers at the top of these bars are the total number of infant deaths in a given year. So in 2010, 626 infant deaths. And again, it's good to know if you look across the 5 years, those total numbers of deaths are going down. But what's disturbing is if you look at the bottom here, these shaded areas, 61 in 2005, creeping up to 131 in 2010, those are sleep-related deaths. So a full 20%, not different from what Dr. Gunn described in Wisconsin, 20% of our infant deaths due to sleep-related causes. And these don't include deaths that were called SUIDs. So we're going to talk about SUIDs versus other sleep-related deaths in a minute. These are sleep-related deaths like suffocation, strangulation. 20% of all our infant deaths in Tennessee. You can see from this map, they're spread out all across the state. This is just 1 year's worth of data. If we were to take 5 years' worth of data, can pretty much guarantee you that every county would have at least one sleep-related death. Because the populations tend to be clustered in metro areas, you tend to see some of the counties with the darkest shading, like Davidson and Shelby, because they are higher populations, but they have the highest number of infant deaths due to these sleep-related deaths across the state. So just to start out, I want to make sure we're all using the same language and terminology. When we talk about SIDS, SIDS is something we've talked about for a long time. Many of you are probably familiar with sudden infant death syndrome. And really what that means is there is no explanation for that infant death. We've done a thorough death scene investigation, an autopsy has been done, the child's medical record has been reviewed, and we still have no idea why this baby died. Compare that to what's now called SUID. You heard Dr. Liu talk about that. And was that a new term for anybody? Has anybody not heard of SUID before? So it's new for some folks, and I see some of the folks in this room that have not heard. SUID is sudden, unexpected infant death. So any death that's sudden and unexpected during infancy, whether it's explained or unexplained. So if you think about, that's really kind of a broad term, SUID, sudden, unexpected infant death. SIDS are a piece of that, but there are many other causes. Then there's this definition or abbreviation that you'll see on some later graphs, ASSB, which is accidental suffocation and strangulation in the bed. Those are those sleep-related deaths that are not SIDS. So Dr. Kim's graphic, which we borrowed, really is nice to sort of explain this SUID versus SID. So again, if you think about SUID being that umbrella term, SIDS is one of the causes or one of the factors that can be a SUID death. Other causes include suffocation, infections, inborn errors of metabolism, cardiac disease, poisoning or overdose or other injury. Any of those things can lead to one of those sudden, unexpected infant deaths. So what is SIDS? We know that SIDS, if you look historically, particularly over the last couple of decades, a major cause of death in infants in the first year of life, most of those deaths occurring between the 2nd and 4th month. SIDS is sudden and silent, often associated with sleep, and with no signs of suffering. So the parent goes in at the end of a sleep period, a nap, or the next morning and finds that the child has died. SIDS is a diagnosis of exclusion. We talked about you can only ascribe that diagnosis if you've done an autopsy, you've done a death scene investigation, you've reviewed the infant and family histories, and you have no reason to know why this child died. Again, we scratch our head at the end and say, we've turned over every stone, we have no reason, it must be SIDS. But SIDS gets overused a lot. People talk about SIDS a lot. So what is SIDS not? SIDS is not preventable, because we don't know what causes it. And people scratch their head and say, well, what about back to sleep, and what about smoking and all these other things? We don't know what causes SIDS, but we can reduce the risk for SIDS. SIDS is not suffocation. If the child died because they were suffocated, that's not SIDS. We have an explanation for why the child died. SIDS is not caused by vomiting and choking or by minor illnesses such as cold or infection, and we'll have a slide that we'll show you in a minute that will help, I think, be a teaching tool for you to use in your communities, because a lot of families, when you talk about, well, why do you put that baby to sleep on their stomach? Well, we don't want them to choke, and if they throw up, it's going to be better if they're in that position, or that's why we put them on our side. It's actually not true. SIDS is not caused by vaccines. SIDS is not contagious. SIDS is not child abuse or neglect. So if there's underlying child abuse or neglect that has caused the death, we would hope that would come up through the history or the death scene investigation or the autopsy. And SIDS is certainly not the cause of every unexpected infant death. So again, you saw that slide earlier with things like infection, things like other injury. Those can cause infant deaths, and those would not be classified as SIDS. So if you look nationally, the trends in SIDS and other sleep-related deaths, the triangles that are at the top of this, the top line, are all the SUID, all the sudden unexpected infant deaths from this period of 1990 to 2006. The diamonds that are in the middle, this middle line, those are the SIDS deaths. And then this line on the bottom represents unknown or those suffocation or strangulation deaths. So you can see that those have risen, whereas the SIDS cases have come down. And there's a lot of question about why that's happening. One of the thoughts is that we're doing a better job of calling something SIDS versus not SIDS. So a lot of effort that's happened in Tennessee over the past decade in training first responders. When you go to a home where there has been an infant death, what do you look at? What do you want to see in that death environment? You want to look at the crib. You want to talk to the family. As you can imagine, it's an incredibly traumatic time when a family has called a first responder because a child has died. But it's so incredibly important to know those details of that death environment so we can see, is there something that was a cause of this death rather than just calling it SIDS. You can see this is, again, national data 1990 to 2006. The dark bars are 1996. The lighter bars are 2006. So we've seen declines in SIDS and other sleep-related deaths over that decade. You can see that among non-Hispanic Black and American Indian and Alaska Native populations, those rates are still higher than in other populations. So just as we talked about disparities in the overall infant mortality rate, there are disparities among sleep-related death rates nationally as well. Now, Dr. Gunn talked about the why, and it's so important to know the why, because we could all leave here and say, there are a lot of sleep-related deaths in Tennessee, we got to go do something about it. And it's probably those parents who are drunk and intoxicated, or those parents who are obese and are just too heavy, and when they roll over on their kids, they're not going to feel it. Right? That sounds like a very logical argument. Well, it's not what our data show. So that's why it's so important to get to the why. Why are these deaths happening? And so we're fortunate in this state to have a really robust child fatality review process. Is anybody in this room on a local child fatality review team? Excellent. Thank you. Not easy work. Not fun at all to review cases of kids who have died. But incredibly important work because it gives us data like this. And so what we know among children who suffered sleep-related deaths, and this is small, but it will be on your thumb drive, so if you want to blow it up and look at it bigger, you can. 82.2% of those sleep-related deaths, the infant was found sleeping not in a crib or a bassinet. 59.7% of cases, the infant was sleeping with another person. And in 45.7% of cases, the infant was not sleeping on their back. Now, we want to think again about those parents who were intoxicated, right? Or the parents who were obese. Well, in our child fatality review data, only 3.1% of the sleep-related deaths occurred in an environment where it was an obese adult sleeping with an infant. Less than that, about half, 1.6%, for both alcohol-impaired or drug-impaired adults sleeping with the infant. So we tend to rush and say it's those bad parents who are making really bad decisions and doing bad things, when in fact we know that there are other larger factors that are the leading causes of sleep-related deaths for our infants in Tennessee. So this is going to be important as you think about going back to your community and getting to the why and then figuring out about the what. What are you going to do about it? And I think, we have this conference, we talk about infant mortality rate, we have a whole breakout on sleep-related deaths. And you could say, well, what's the point of all this? Why are we talking about this? Well, remember we said it's 20% of all infant deaths in Tennessee. So in 2009, if you look at all those cases of infant mortality, 526, 129 were sleep-related, 526 from all other causes. If we took out those 129 sleep-related deaths that occurred that year, we would go from having an infant mortality rate of 8.0 in that year to an infant mortality rate of 6.4. Now, what's really impressive about that is that 8.0 put us in the mid-40s. That's where we've tended to rank in infant mortality. 43, 45, 47. This 6.4 in 2009 was the national average. So just addressing those sleep-related deaths takes us from the 40s to the national average. Now, I say that, it's not exactly that easy. I said just addressing those infant deaths. If only it were that simple. But think about it, 20% of all our infant deaths, this is something we can wrap our hands around. This is something we can do something about, and it will have a huge impact. And getting back to the numbers that Dr. Gunn talked about, beyond getting us to a rate of 6.4, that's 129 babies that could be saved in this state every year by addressing sleep-related deaths. Put in different terms, in 2010 there were 131 kids, 6 kindergarten classrooms that were empty. And you heard the First Lady and Commissioner talk about that. It's really important to translate those numbers sometimes because if we're talking to the general public, people don't understand what is a rate of 7.9 or 8.0, and sometimes rates respond in funny ways if the numbers are very small, and it can be helpful to translate it into these very real numbers. 6 kindergarten classrooms. Folks can get their heads around that. They can visualize that and think about the impact of that. So what are the current recommendations for infant safe sleep? And this is where we will turn over to Dr. Kim.
So when we talk about the current recommendations for infant safe sleep, there's a lot of work that's been done, and especially through the American Academy of Pediatrics that has stayed abreast of this issue since probably long before I was in residency, and I'm sure that was probably a little bit before Dr. Warren was in residency. But as far as making sure that we have this information and it gets out into the literature and to the providers and to the people who are making a lot of the educational decisions about how we address this with our future providers. And the expansion of the recommendations for safe sleep to include environment. Previously, it was really more about SIDS reduction, but now talking more about the safe sleep issues and where does your baby sleep and how does your baby sleep has really changed a lot of what's been put out there around SIDS. So we know ABC. Everyone should know ABC. If you don't have an ABC, raise your hand if you have an ABC pin on. All right, look around at your public health champions and applaud them. Very good. And see, y'all could have just put it on if you cheated and looked. But this idea of trying to make it simple, ABC, alone, on your back, in a crib, something that you can easily kind of transfer to other people. If you know anything about education, things come in threes. If you have 3 things, it's much easier for people to remember. Alone, on your back, in a crib. And alone, really getting into the details about alone means not with another child or a pet. It means alone, by yourself, no other living thing in there. Not with pillows or stuffed toys, all those great things that you get at baby showers. Leave those on the shelf someplace else. And not in a crib with bumpers. And that's probably one of the hardest things because bumpers are so incredibly popular in stores and in newborn nurseries. On their back, not on your side, of course, not on your stomach, but on your back. And of course, in a crib. And a crib may also be a bassinet. If you don't have that, that might be a drawer, but meaning that it's an enclosed structure where their child can be by themselves. But especially not on a couch, not on the 15-inch pillow soft mattress that everyone has now, and definitely not in the chairs. So why does this matter? Again, AAP has done a lot of work in this, and in 2011 came out with the technical support that really talked about the odds of sleep-related deaths and how much it increases if that child was sleeping on their belly, okay, and also how much it increased if they were sleeping on their side. It used to be that it was thought that sleeping on your side was safe. And this has been one of the biggest, we'll say, learning curves we had working with our health professionals because it was put the baby on their side. Most nurseries in the country, baby is on their side. So changing that practice has been, we'll say, very slow for adaptation. But the fact that the odds ratio increases to 8.7 if you're a number guru for infants placed on the sleep on their side that are then found on their stomach. There's also data that shows that infants that normally sleep on their back and then go to daycare or childcare and are put to sleep on their belly are at a much greater risk of dying because they're used to sleeping on their back. So just something else to kind of keep in mind. And Dr. Warren mentions these pictures, and these are great because the urban legends about what happens if a baby sleeps on their back, and of course they're going to choke because all babies throw up. They all, gurgle up some of that formula, and obviously if they're on their back, it's going to go right down the windpipe and they're going to choke to death. And you can see from the anatomy that, the body's it's just a little smarter than that, and it doesn't happen like that. If you look at where the esophagus is versus where the trachea is, on the side you can see how much easier it theoretically would be for that child to have problems if they're sleeping in this position versus like this, okay? You would think that if you gurgle up something, gravity is going to take it back, it's going to go down your esophagus, opposed to, hey, I'm going to float up and go down your trachea. Okay, so think of some of the anatomy when people come and say, well, the baby is going to choke. And these pictures, as Dr. Warren said, will be on your flash drive, and they're great tools to take into the community. It's kind of like the brain cards, if you've ever seen the brain cards about prematurity, that just sometimes a visual is worth 1,000 words. So let's talk a little bit about bed sharing. When we looked at some of the studies that have been done, 11 case control studies, that odds of sleep-related deaths was 2.89, or almost 3 times greater for infants who shared beds. Okay, so 3 times risk. That younger infants, it was even higher, and with smoking moms, it was also higher. So we have kind of a picture of danger here. If you smoke and you sleep with your child, that child is in imminent danger. So, but no single study showed the reduced risk of SIDS in bed-sharing infants. All studies found that there was an increased risk. So if you ever need a compelling literature response, there's it. If nothing says that it's a good idea, then it's a pretty strong statement. So when we look at some of the other safe sleep recommendations, regular prenatal care for pregnant women. Why is that important? Because you get the message over and over and over. The more times you hear a message, the more likely you are to build a neuron that says sleep self, sleep by yourself, opposed to some of the other kind of conflicting things that may be going on in your brain. Avoiding smoke exposure. If you're in prenatal care, also that issue about being able to have access to quit lines and to cessation information will help, because we know that smoking is a serious, serious issue. Avoiding alcohol and illicit drugs, even though it's a small amount, every number counts. The importance of breastfeeding. Breastfeeding has been found to be protective. And also avoiding overheating. Okay, some people think, I love sleeping in 5 pairs of pajamas and 3 blankets, so obviously my baby wants to sleep like that also. No, don't do that. Considering a pacifier. Why? Because babies suck on pacifiers, and often it's done as kind of a what do you want to call it, an involuntary response where they're just sucking. And if you're sucking, then you're breathing. And sometimes in situations where that airway may get closed or get occluded, that sucking action actually helps. It kind of also wakes the baby up a little bit, which can make it easier to breathe. and immunizing according to the AAP schedule. Why? Because pertussis and some of the other infectious diseases that can affect babies. And of course, avoid commercial SID risk reduction devices, the wedges, and all of those things that people are getting very rich off of. So, but before we do this, because one of the best things of public health is that we say, just say no. We say no to smoking, we say no to drugs, we say no to sex, we say no to just about everything. So just say no to your people about don't co-sleep, and that should work, right? No. Because sleep is really related to parental beliefs as a very big issue. So what are the parents' beliefs about infant sleep? Is it they're sleeping like this because it's a lack of there is just absolutely no way that there's a relationship between SIDS and sleep position. If that is in somebody's brain, it's very hard to say, you just need to not sleep with your baby. It's because, yes, doctor, I hear you, and then they go home and do what they want to do. So it's important to make sure that you understand what the rationale that they're using behind sleeping with their child. Since SIDS is kind of unknown, then how do we know what the risk factors are? Okay? And if grandma says that that's not a risk factor, then I don't believe anything you say anyway. So knowing what those risk factors are, understanding the inconsistency of recommendations. I say don't do it. Someone over here says do it if you do it this way. Someone else over here says don't listen to that, just go ahead and do it. So there are so many conflicting messages that our patients and our clients and the people in the community we work with are getting that it makes it hard to filter it all out. And on and on. So no back sleeping positions based on infant preference. Well, he's just not comfortable. And if you tell a mom who is sleep deprived to turn their baby over when, yeah, they may not cry as much on their stomach, but, you know, I'd rather have a crying live baby than a dead quiet one. But if you tell them that and are already sleep deprived, then again, you're going against some other messages that may be coming out there. And that knowledge is not necessarily associated with safe sleep. We know, but we don't necessarily do. Who had a donut this morning? Okay, you know donuts are fattening, right? And you ate it anyway, right? Okay, so it's not about knowledge. So, okay, had two. Okay, see, that's why we put you up front. And reasons for, you know, room sharing was mentioned earlier, and something that we've seen a lot with the economic downturn is families who are moving into each other, 3, 4 families, 20, 15 people all living in 2 or 3 rooms. If you do that and say, you need to set up a crib, I mean, I'm sure that if they could, they might. But space is a significant issue. There have been issues of safety. There was, and you know, you hear the stories about from child death about what might be the causes, but sometimes in the FEMA programs, you hear some of the stories that get even deeper into about why someone may have co-slept. And this issue of safety and wanting to protect your baby and do some other things like that comes out, saying, I wanted to protect my baby, so I needed to have that baby sleeping with me. I had a case when I was practicing in Boston of a family that lived in a very unfathomable environment that probably had more rodents in the house than beds or anything else. And they slept with the baby because their thought process was, it'll bite me first, and that'll wake me up and I can protect my baby. And so unless you actually get down to some of those issues and some of those thought processes, and we just say, just do what I say, then you miss kind of forming that relationship. So again, you have all of the reasons. Baby's fussy. It's easier for breastfeeding. You know, I can watch the babies. Avoiding environmental issues. All of these things that come into play when a parent decides actively where my baby is going to sleep. And more just as far as issues of, I want my baby to be comfortable. And we've had several cases in child fatality about parents that have put the baby very nicely on a pillow propped up because they wanted them to be comfortable, not realizing that that pillow they slide and then they ended up being a SUID case. Misinterpretation of a firm surface, what's firm to me might not be firm to you. Okay, so if I have a pillow top mattress and it seems like it's firm to me because I have a nice taut sheet on it, then I may be trying to make a good decision, but in actuality, my information may just not be correct. And of course, you know, this whole issue of bedding used to prevent the infant rollover. We've had babies that have suffocated when they get wedged in beside something because of the actual wedge that they put, or the people that have put the pillows around the baby to make sure that they don't move, and they end up moving and falling into that pillow. So when we look at sleep positioning in Tennessee, you'll see that almost half of the babies are not sleeping on their back, almost half. And when we look at how often does your baby sleep in a bed with somebody else, again, you can see between sometimes, often, and always, very large numbers. Only 30% said never. And I can guarantee you that rarely may have a different definition for me than you. Okay, rarely means only once a week. That's how often I eat cookies. Rarely. It's only once a week. But, you know, when you think about that way and figure out that this is an issue, that the information that we're putting is out there, but the action is not. And so there's that gap there. And when we look again, bed sharing, if we look at the populations that are more at risk, young people, we look at the people under the age of 20, there's a slight increase. If you think of where people under 20 are, Dr. Warren, all right, I'm from Massachusetts, so I'm going to speak Boston now, which means I'm going to go really, really fast. But younger people would be more likely to sleep with their child because most young people are still living at home with a whole bunch of other people and they don't have a room separate for their baby. So they're going to be more likely to sleep together. Less educated, again, you're going to have less space if you tend to be less educated. Lower income. So it goes into these issues about what that risk factor or that risk profile of people that bed share is. But again, understanding what goes into that thought process is important. And then we have those of us healthcare providers that also give inconsistent messages. Half of my pediatric friends sleep with their baby. You know, how are you going to tell your patient not to do it if it's something that you're doing? So we have a lot of issues in that also. In the NICU survey, 95% recommended positioning other than sleeping on your back. So this is what we're up against. And if our physicians are not practicing, then how do we get other people to do it? Child care providers, again, the American Academy of Pediatrics makes a big deal about making sure that the child care providers also have this information. But in actuality, if we look at child care centers, it's not something that's really, really regulated. I've been in the many daycare centers. Our female interviewer, Pam Taylor, who does a lot of safe sleep information, goes to daycares and talks to people, and everyone's going to say, yes, all the babies sleep on their back, but you can see it in their faces when you're doing the education sessions that may not be the actual deal. So where do patients get their information, or parents? The internet is a wonderful and an awful thing. Blogs, you know, the amount of false or kind of erroneous information that's going around in blogs is scary. Okay, so when you talk to parents or to people in the community about where do you get your information, and just beware of what they might be getting on the internet. You can find anything you want on the internet. If you want to sleep with your baby, you'll find enough stuff that says that's the best way to do it because there's just so much copious information out there. Magazines, we've seen the pictures. We've seen J-Lo's Nursery with the twins with everything floating off of everywhere and pillows and animals. And so, again, these mixed messages. And then we get our racial differences. We know that African Americans are more likely than non-Hispanic whites to sleep prone and less likely to sleep supine. We know that our Hispanic population are less likely overall to sleep prone. And we know that people who have low birth weight babies or infants that are in big, big families are much less likely to sleep prone also, or to sleep supine. So I'm going to do a real quick, just talking about culture, because culture takes a big interest in how we sleep. And it's one of the things which I thought was fascinating. When you acculturate to somewhere else, one of the last things that goes is practices about sleep. Okay, so just think about when you think about your population. For most of human history, where did babies sleep? They slept with their mother. Okay, and so in a lot of places around the world, most countries or most poorer countries where you may have everybody sleeping in one room because that's all the house is, most people are still sleeping with their infants. So when we say the baby must sleep alone, you know, that's something that's saying it's against my culture. And if we don't recognize that as being an important issue, then we've alienated that person from our message in the first place. So if you look at some of the studies, Meredith Small, anthropologists love this stuff. 55% of white parents and 70% of African Americans said that they co-sleep. But the reason was a little different. Okay, the white parents that he interviewed co-slept with their babies because it was perceived to having sleep problems. They were waking up during the night, or when there were attachment concerns and you felt like you were a bad parent if you weren't sleeping with your baby. Whereas the African American parents co-slept, and it was just the norm. There was no reason behind it. That's just what you do. Everybody does that. So we have to understand some of the issues like that. Other studies that have been done showed that in cultures, there are basically 4 types of sleeping households. Either mom, dad, and baby in another bed, mom and baby, dad goes off someplace else, everybody's in different beds, or everybody's in the same bed. And understanding what culture that person comes from and what's the cultural norm is important. I don't know how many of us ever ask. So in your country of origin, how do families sleep? Just something to think about. And so co-sleeping was common in warmer climates. So if you have people who are coming from warmer countries, that may be more popular. And mom and baby was something that was almost sacred. So just be careful. And this all information will be on your flash drive. But just about the issues of what we come up against. In this one study of 186 non-industrial societies, 0% of the infants were slept in a separate place before they were 1 year age. Okay, so if you have a large group of populations that come from cultures like that, again, it's different messaging that you have to get. And if you look at this schematic between culture, family, infant-parent biology, public health, science is way over there in the corner as far as influence. Okay, so it's kind of like that saying that there's a great saying about, culture and habit and everything else is kind of paramount. The science behind it is pretty much irrelevant to a lot of people. So we have to be careful that we're not just espousing data on people, but really talking a little bit about why they do what they do. So interventions in Chicago, educational presentations in WIC clinics and other public health clinics has really helped to change people's behavior according to pre- and post-clinic surveys. The same in Norway, where they did TV and newspaper and magazine ads. And if you've seen any of the bus wraps or the signs in Nashville, we're hoping to have some of these same effects also. Nursing training, talking to the people in hospitals, anyone from the social worker to the people that might come in and just deliver trays, or anyone that may have some kind of a conversation with that parent about the risk of SIDS. Healthcare workers, et cetera, and then again, of course, our child care providers. So if we're able to get a lot of that information out, but understanding the cultural context which that it's coming to us in, then we'll probably be much more successful at getting down to that 6 by those preventable deaths right there. But if we keep doing it the way we've always done it, which is just say no, then we're probably not going to move that needle. So before you counsel someone on safe sleep, take a step back and try to get a better idea of where they might be coming from and what kind of, I'll call it sleep baggage they may be bringing with them.
All right, so hopefully you heard in that last few slides by Dr. Kim some concrete things that you could think about taking to your community. There's probably a WIC clinic in your community. In fact, we have WIC clinics in all 95 county health departments. So thinking about how you might partner with WIC to provide educational messages. Many of you are connected to hospitals. I know some Vanderbilt folks on the front row. There are other hospitals represented here as well. How are the babies sleeping in your hospital? If we were to go to not your NICU, but your term nursery today and do a crib audit, how many of those babies are on their back without a lot of blankets, without a thermometer? You heard stethoscope when Dr. Gunn was talking earlier, all sorts of things, maybe a measuring tape, all sorts of things that are in that crib. How many babies would we find that were alone on their back and in crib or bassinet? If you are part of a general, sort of a broader community organization, what sort of public awareness can you do? Dr. Kim talked about some of the things that had worked in specific cities like Chicago, but at a broader level. Some of the European countries that have done these broad messaging campaigns. You heard from Dr. Gunn about what's been done in Milwaukee. So lots of things that you could do to take back to your community to address this. We wanted to sort of highlight some of those to give you some ideas so that as you go to lunch and regroup with your team and as you have that hour from 3 to 4 this afternoon, you can think about, if we want to tackle safe sleep in our community, what might we do? So general community education. Maybe you want to do some safe crib displays in public spaces. Banks, post offices, faith-based communities. Get a crib. Put that crib out there to show people this is what a safe crib looks like. Maybe you write an article for a local newspaper or organizational newsletter. Give a presentation to a community group. Many of you who are here represent public health agencies, community organizations, healthcare entities. You are knowledgeable about maternal and child health issues in your community. People look to you as experts. Put that expertise to work. Go talk to them about safe sleep. Many times it's not even on their radar. If you say, why are babies dying in our community? And you say, because of safe sleep, they're going to look, what? They don't know. So go provide that information for them. And then think about helping being parents, share a story of an infant lost. Now, this one is tricky. But for those of you who are connected with FEMR, the Fetal Infant Mortality Review Groups, those of you who work in hospitals where you're connected with bereavement programs, think about if there are opportunities to connect with families who have lost babies. Baltimore City Health Department has done a really nice video. If you go to YouTube and Google Baltimore ABCs of Safe Sleep, they've got a really nice 7-minute video. Have your Kleenex beside you. But it is very powerful. 3 moms who tell their story. 3 moms who lost their baby for entirely preventable reasons, sleep-related deaths. Think about how you might use a story like that in your own community. Again, something very delicate, but if you have an opportunity, is there a way to help those parents share what they've learned? Sure, if you just go to YouTube and then Google, in YouTube, look, Baltimore ABCs of Safe Sleep. If you can't find it, email me and I'll send it to you. So again, that general community education will work. If you work in a hospital, maybe provide an in-service training on these new recommendations for safe sleep. Maybe we're doing okay on the back to sleep because we've been talking about that now for, I think, a couple of decades. But what about the alone piece? What about in that particular sleep environment? What about the recommendations for bed sharing? Share it with our colleagues who are in hospitals. Maybe you want to develop an infant safe sleep policy. We know it's the right thing to do, but sometimes if it's in policy, by golly, we're going to do it because somebody's going to come around and with a clipboard and make sure that we are doing those things, right? So maybe do a specific infant safe sleep policy. Find ways to share those safe sleep messages with new and expectant parents. And we're going to tell you about some free resources you can use to do that in just a minute. And maybe even think about distributing safe sleep onesies in the newborn nursery. Now here is an example of where it's cute. The literature doesn't say it's very supportive of actually changing practices, but parents like things to take home. So if you've got the resources to be able to do something like that, it may be something that would help. The literature is not going to say it's going to help necessarily reduce those sleep-related deaths, but it may help open a dialogue with a parent so you can share a message with them to talk to them about safe sleep. Child care centers. You saw the grid Dr. Kim showed earlier. We were really surprised when we were putting together this presentation. For the large group daycare centers that are in our state, their policies align very firmly with the new recommendations in terms of alone, back, crib, training for child care providers, all those things. But if you look at the family care homes, we have a lot of room for improvement. Not as tightly regulated. Kids are still at risk. A child who's in a family care home is just as much risk as a child who's in a large group care home. And we want to make sure that those same messages are getting there. Think about if you want to work with child care providers about partnering with the child care resource and referral centers. We have, I think, 10 of those across the state. Great resources for you to think about and partner with because they work to provide technical assistance to child care providers. Again, infant safe sleep policy. Ask your local child care center, do you have a safe sleep policy? Do you train your staff in what to do when it's time for those infants to go to sleep? And don't forget those home-based child care centers and church nurseries. So walk through your church nursery, look at, see, are there bumper pads? Are those babies on their stomach or their back? Are there a lot of other things in that crib? And be an ambassador for safe sleep and take those recommendations. Again, working with faith-based communities, think about providing safe sleep inserts for congregation bulletins. Most congregations have some sort of message board that's outside their building. Think about putting a safe sleep message there. Again, safe sleep policy. Go back to that nursery, and if there are policies for that church nursery, do a safe sleep policy. Again, working with caregivers, partner with home visitors, other child and family serving agencies to get safe sleep information out. And we think about a lot of times going after young parents, but don't forget grandparents. We have a lot of kids in this state who are raised by grandparents or spend significant amounts of time with grandparents. Those grandparents are going to be putting them down to sleep. And it can be hard to change grandparents' mind. I will tell you, even as a pediatrician, when I talk to my mom, who now has this 4-month-old grandson, it can be difficult to say, why'd you put him on his stomach? Or why did you put him on his side? But you've got to have those conversations. Don't forget the grandparents. And then think about distributing cribs or pack-and-play units to parents who need that space for safe sleep. Some parents will tell you, I really want to do this, but I can't afford a crib, can't afford a bassinet or a pack-and-play. A lot of times there are resources in communities to help do that. There's a national program called Cribs for Kids that can be implemented at the local level where you can buy cribs or pack-and-plays at cost and share them with families. So we're going to close with talking about what the Department of Health is doing around safe sleep. We have a lot of materials, and we have them here.